Thank you very much for your questions. The question was, how is that young man doing that I talked about earlier, that young man that was a bilateral amputee. He's actually doing much better. His pain, we were able to get it to a 4 to 5 over 10, and he's now employed. And really, more than anything, it was just the opportunity to be around people and being employed that has also really helped with his health. Now, just to give you an idea of the next part of it is to kind of let you know about what happens to us when we have chronic diseases, acute diseases that will eventually lead to chronic pain. We develop a variety of different symptoms, and what it causes is changes in lifestyle. And we see these changes in lifestyle causing metabolic factors to be released. These inflammatory factors, we sometimes call inflammatory cytokinins, then cause an effect on our health, so subsequently creates then a chronic condition of our health that sometimes we have a very difficult time breaking and coming out of it. So we have symptoms like fatigue and midday energy crisis and insomnia. Nothing worse than insomnia when you have chronic pain management or chronic pain and you're not able to manage the pain appropriately. You can't sleep. If you don't sleep but 2 or 3 hours a night, you're going to be pretty difficult to manage the next day. I mean, not only you, but also the people around you. The abdominal fat, the gaining weight, body aches, anxiety, depression, hopelessness, constantly being worried about what's happening to you, a feeling of being overcommitted, that is to say, I'm trying to control the pain, I'm trying to control my disease, I'm trying to control my life, what do I do first? Sometimes apathy, flat affect, you give up, you don't care anymore, you get burned out. And sometimes we see compassion fatigue, we see that very oftenly in caregivers with patients that have severe dementia. The caregiver starts taking on the patient's symptoms. And then, of course, the cravings that's associated with chronic drug abuse. So these inflammatory cytokinins have a variety of different, very specific names. Tumor necrosis factor alpha 2A, tumor necrosis factor beta, interleukins 4, 6, and 10, the COX inhibitors, the cyclooxygenase cascade that occurs in prostaglandins, and then, of course, MICs, macrophage inhibitory factors. Cortisol plays a tremendous role in inflammation and disease. Usually that's very important because that really is what wakes us up from midnight on to 8 or 9 o'clock in the morning. And it also causes our blood sugar to be very high, but also is one of the causes of heart attacks. Heart attacks occur between 2 o'clock and 8 o'clock in the morning due to circadian rhythm and cortisol factors. We have a metabolic syndrome that occurs because of high blood pressure and diabetes and high cholesterol. And, of course, obesity and insulin resistance, which is not the insulin type of problems with insulin in the sense that insulin does not tie to that particular receptor due to disease, inflammation, and obesity. Pro-inflammatory factors that we talked about, these cytokinins. And then, of course, genetic factors that have a lot to do with vitamin D deficiency and could be a problem with the methyl tetrahydrofolate reductase inhibitors that don't work or they're absent and subsequently cause the vitamin D deficiency, which is very important. When we look at actually the criteria for substance dependence, and incidentally, recently there was a merging of criteria for substance dependence and abuse in the DSM-5, we look at this cycle that occurs. If I leave you with anything, I want to leave you with this very important notion of how we describe this: preoccupation or anticipation of obtaining drugs. So you start taking a little more than you should, and then you start lying about how many you took, and then, of course, then you have this persistent desire and this preoccupation for getting more medication. How am I going to get some more? I need more. I used all of them, and so forth and so on. And then you get into these binges, these binge intoxications, where you have then changes in tolerance of the medication, and therefore you have tolerance withdrawal, and you have a certain physical and psychological craving for these medications. Then you have this negative type of effect, this withdrawal, a negative effect that causes you to have persistent physical and psychological problems. You cannot cope with the disease anymore. You can't cope with the disease, so you take more medication. And then, of course, you have social occupational and or recreational activities compromised. But more importantly than anything else, you develop this spiraling distress of this preoccupation, this binges, this withdrawal negative effect that eventually lead to persistent and intractable type of addiction. When we define addiction as this chronically relapsing disorder, is defined by two major characteristics: a compulsion to take the drugs with a narrowing of the behavioral repertoire toward excessive drug taking, and a loss of control in limiting intake by the American Psychiatric Association and the World Health Organization. So what that basically means is that you've lost control. You've lost control of being able to take medication. Drug addiction is not a static phenomenon. As with other biobehavioral dysregulations such as compulsive gambling or binge eating, which are different components and that constitute a cycle or a circle of overgrowing pathology. But it's derived from a social psychology and conceptualization as sources of self-regulation failures. The addiction cycle has been described as having three components: preoccupation, anticipation, binge intoxication, and withdrawal negative effect. So those are, as we discussed earlier, the things that really cause the spiraling stresses that continues with the addictive behavior or the aberrant drug-taking behavior. The stress factors are very, very important, both external and internal, so endogenous and exogenous type of things that happen in our body and our brain. And these stressors really are the ones that cause this perplexing pathophysiology of this continuum of overactivation of normal activity, arousal, or emotional systems of the body. And let me describe this for you. Such arousal activation mechanisms trigger biological and behavioral strategies of coping and control that mobilize many orgasmic and central nervous mechanisms whose failure leads to illness. Okay, what does all that mean? That means this progressive cycle of this binges, this withdrawal, these stress factors create a whole different neurobehavioral, neurobiology, change in neurocircuitry in the person, so that the normal way in how we behave is totally changed. Now, most of us, from a perspective of being humans, we practice from a homostasis principle, which corresponds to mechanisms that maintain stability within our physiological, psychological, and it really holds us in certain parameters of behavior as far as internal milieu behaviors with limits that allow organisms to really survive. What are these adaptations that we have to do to survive? So the homostasis says that how the majority of people work. When you have pain, when you have disease that causes you then to move to another situation, okay, then we call this, this can be described as possibly allostasis. And this involves the whole brain and body instead of simply just local feedback systems. So the whole, once again, the neurobiology changes, and this homeostasis, which is the normality that we generally have, we change biology, behavior, neurobiology, and neurocircuitry to this whole different level that we call allostasis. So, therefore, it's very hard then to come back after you've done this aberrant behavior and this psychological behavior for a long period of time. It's very hard then to come back and be normal. It's not going to happen with a single drug. It's not going to happen with one single treatment. It requires sometimes months and years for you to change that neurobehavior, neurocircuitry, and by behavioral situation back to a homeostatic part. And very few really are able to do that. So such changes in hormones, opiate transmitters, and so on, all of these have a tendency then to cause this chronic arousal, repeated stress, and negative affective states that impose a prolonged regulation far from normality. So you have almost a change in that person. There are some patients that have what's called pseudoaddiction. And pseudoaddiction is when a patient has been inadequately treated, or not adequately treated, or titrated with the appropriate medication at the right time, and they seem to have severe pain and almost a drug-seeking behavior that stimulates or simulates true addiction. But these patients really have not received the right dose at the right time and the right frequency to really manage their pain. And I've had the privilege of taking care of some of these people, and sometimes they require a very, very large dose of opiates, 2,000 to 3,000 to 4,000 milligrams of morphine or other types of drugs, opiate rotation adjusted, and also non-opiate medications. When we look at challenges for substance abuse, we have to look at it kind of more or less, how is it that we address this disorder in patients? Do patients with substance abuse and substance dependency have true pain? Yes, they do. Okay? And that pain should be treated. The American Pain Society very clearly says that we should use the right medications to address that pain. Just because they have substance abuse or substance dependency doesn't mean that they have true nociceptive, neuropathic, or inflammatory pain due to chronic diseases. Say, for example, you have a patient with ALS or a patient with multiple sclerosis, and they have had a history of substance abuse and substance dependency. Would you know that they're having nociceptive, neuropathic, and inflammatory pain? And we must treat that pain, but monitor them also very, very closely. The American Society for Addiction Medicine looks at the 4 C's as a way of making sure that patients receive adequate pain medication for their disease and control abuse. But what happens is they have loss of control over their use of medication, compulsive use of medication, continued use despite harm, and then, of course, craving for medication. So those are the 4 C's that they encourage us to focus on as we care for patients with chronic pain management. There is situations where chronic pain exists, like I mentioned, in addicted population, and so we need to find out how is it that we can differentiate between the physical aspects of pain, the psychological aspects of pain, and sometimes the spiritual aspects of pain. So under-treatment in chronic pain with patients with substance abuse does occur. And so subsequently, they don't get the right medication, and they are continually drug seek. They may fall into that pseudo-addiction category, or they may have a true substance abuse and substance dependence. So we have to make sure that we develop a patient-level factor, understand them, know where they're coming, and be very disciplined about the care that we provide. We have to have a physician-level understanding and knowledge, and also a little bit understanding the psychology and the behavioral problems that that person may have. And then the system level. We cannot abandon these people just because they have abuse and dependency. We must take care of them. We must provide them with the care that they want. We can't just say, well, it's a problem, or in this system we don't take care of any of these patients. No, it's our obligation to care for them as well. When we look at patients also as far as treatment considerations for chronic pain, it's important that there is a trust developed between the patient and the physician as a relationship, and that very specific goals of treatments are characterized. I've had the privilege of taking care of patients that are physicians, that are lawyers, and that are nurses in these situations, and making sure that we get the right drugs at the right time. We develop certain things so that we make sure that they have the discipline. I have a rule of 3, and I tell them this right off the bat. If you do things outside of the regimen, now you have to follow my regimen, you have to do it the way I ask you to do it. You don't go behind my back, you don't go looking for other doctors, you don't call on-call people or doctors that are on call for me and try to get more medications. And you get 3 shots at this. At the last shot, I will tell you, you're fired, I will no longer ever take care of you. While I will take care of you, you will have my full effort in managing your pain. I want to help you. I want you to have a quality of life that's substantial to what you think it is and what you think you feel it should be. So there's other options besides medications. And this is one thing that sometimes is not considered. It's very important to look at non-pharmacological therapies. Physical therapy, to me, plays a pivotal role. And you must be sure that when you have, or you contract, or you're recommended to a physical therapist, that they use a lot of different modalities. I mentioned here the McKinsey methodology for patients with back pain, because I'm a graduate of that particular methodology, and I can tell you it works. Yes, I still do 34 exercises for my back pain 3 times a week. That happened several years ago. But still, those are very, very important discipline things that I do every day to make sure that I decrease the pain and stretch my spinal cord so I can reduce some of the pain. Acupuncture, acupressure, TENS unit to work excellently with massage therapy. Massage therapy, hydrotherapy, yoga, breathing exercises, which are very, very important in relaxation. And of course, cognitive behavior therapies, including spiritual nourishment. So very important for the psychologists and psychiatrists to come and help us deal with some of the problems that we have as far as developmental type of situations. And then, of course, lastly, are pharmacological therapies. Looking at substance abuse challenges, we look at assessing response to therapy. Is the pain medication working? Okay. Are there any factors that are affecting their both physical and psychological functioning? Are there any adverse effects of these drugs? Well, not just like constipation, but also euphoria. Is that affecting them? And euphoria is a pharmacological property of the drug. And then, of course, aberrant drug-taking behavior. You have to make sure that they understand that this is a relationship you're building with them that's built on trust, but also built on contracts and agreements. Will you agree to follow this protocol? I agree to follow this protocol. This is the protocol we're following. Any deviation has to be negotiated, okay? We can change and we can negotiate, but it has to be a mutual negotiation. You just can't get into a binge and say, oh, listen, I'm sorry, I just got crazy and took on the medication. No, that's not acceptable. You use toxicology testing. Pill counting is necessary. And of course, you always look, always, serially evaluating the patient for a differential diagnosis of drug-taking behavior. What are some of the risk factors for people with aberrant behavior? Well, you generally see people that maybe have been involved in multiple motor vehicle accidents as a driver, family history of substance abuse, history of legal problems, nicotine dependence, high opiate doses. We'll tell you, oh, doc, you're going to take care of me, but I need 600 milligrams of hydrocodone daily to manage my pain. They may have pseudoaddiction, may be appropriate, and may not be appropriate. Fewer side effects from opiates. Oh, yeah, I'm taking the opiates, but I don't have any constipation. I don't have any euphoria. I don't have some of the normal side effects. I don't have any psychomimetic effects. Mental health disorders. Usually people with schizophrenia, schizoaffective disorders, personality disorders, and bipolar disease. Previous history of active drug abuse. And bring that information forward. If they had it, to let you know what were the problems, what did they do, and how is it that we can avoid that same mistake again. Many medical or physical disorders, younger age, untreated pain, history of prior opiate detoxification, history of termination or limited care from other physicians. In other words, they've been fired by many doctors or nurses or dentists or chiropractic physicians. Personal belief in one's addiction. What I mean is that they believe that their addiction is not something that can be treated, that it can only be treated with the drugs that they're taking. And, of course, history of childhood sex abuse or any type, whether it be verbal abuse or physical abuse, and then an unwillingness to sign an opiate contract. Those are very important sentinel markers to kind of help you make a decision as to what's happening to that patient and making a decision. And you have autonomy when someone comes to see you, okay? And if you feel that you cannot provide the care that they need, then you need to tell them that, okay? And you need to tell them why, okay? Whether because you don't have the resources, you don't have a team, or whatever it is that you can't help them with. They need to know. It's not like, well, you're taking too much drugs, I'm not going to take care of you. Explain to them why. Why is it? And why is it that you can or you cannot take care of them? The federal government, both the DEA, the Drug Enforcement Administration, and the FDA, the Federal Drug Administration, are moving forward with what's called risk evaluation and mitigation strategies. And the biggest thing is the program is very concerned about opiate deaths and opiate overdoses. And so they're wanting to regulate this a little bit more so that we have a better idea and, more importantly, better education. And this is part of what I'm trying to impart to everyone that's listening out today, okay, is that the people will, if you just hand drugs, if you just write prescriptions willy-nilly, without assessing patients appropriately and knowing all the pharmacology and the pharmacokinetics and the pharmacodynamics and the use of non-opiate medication, really you're going to get yourself into a situation where you potentially may compromise your profession and your licensure. The DEA is also considering adding hydrocodone to this list of C2s that are required. This would have a major effect. I'm hoping that they won't, but if they will, this is going to affect how we practice medicine on a day-to-day basis. Okay. Tramadol is not equivalent to hydrocodone, and so therefore we'll be limited in what we can give patients, even elderly patients with a hip fracture. What medications can we give them? I don't think a lot of physicians are going to feel comfortable in the emergency room writing for C2s, so it'll be a major shift in how we do pain management on a day-to-day basis. Now, many times people will talk about how is it that they came to this situation, and they dwell on this situation. I'll tell you a short story. I take care of a lot of patients with severe Alzheimer's disease, and I was doing a presentation. It's a part of a 3-part dementia series that I do. And there's this 86-year-old young lady, part of the material lead, that was in the audience. And she, at the end of the program, said, "Dr. Peralta, I have lunch with my 4 friends every day. And all I hear is they hurt here, they can't do this, they don't do this. And you know, Dr. Peralta, I told them today, just get over it, okay? Do what you can do. Don't tell me what you can't do, but give a positive spin to things and do what you can do." So I want to share with you these words by Carl Jung, back in 1930. He mentioned that the tragedy that happens to us when we don't really consider the opportunity we have in our lives. Okay? And he states here that in our part of the world, that the developmental tasks at the second part of life seem unknown to most people. We lead our lives in an erroneous apprehension that continuing with the task of the first half of life is all there is. As a consequence, many of us meet our death or our success as half-developed individuals, exhibiting signs of depression, despair, fear, disgust with ourselves and others, together with a feeling that life has been uncompleted or wasted. Which implies sometimes that maybe we should consider how other people and other people of the world consider how they live their lives and how we live our second part of our life. And I think this is what my friend was trying to say. You know, if you've had psychological problems, if you had illness, you have to, within yourself, find that oneness that will help you create a paradigm shift so that you can start looking for positive things that will improve your life. Whether you find it through meditation, whether you find it through spiritual practices, whether you find it through counseling, whether you find it through the fact that you feel that maybe somebody's alleviated your pain and you can move on forward. And that can happen as well. So there is this type of psychosocial moratorium that was described by Erik Erikson, one of the developmental theorists. And he basically says that this template really changes, creates a template or transcendence from a child adolescent gradually to become an adult. What makes us an adult? What keeps us from being an adult? What allows us to be an adult and do the things we do on a day-to-day basis? Is it age? Is it your job? Is it your family? Okay? What is it? There are people who have never matriculated from this adolescent stage to an adult stage. And you come across them because they're adult children or adult child. And they didn't develop through this particular stage. And it's important to recognize that, especially in patients that have substance abuse and substance problems. When we talk about getting through this particular phase of life, when we talk about being able to move on, we talk about healing. And I want to share just a very short story of the patients that I've taken care of, one story of many patients that I've taken care of that are young people with cancer. I met a 39-year-old gentleman, severe chronic pain, with a very rare type of cancer. I met him after he had gone to some of the best facilities in the United States for treatment of his cancer, and there was no hope for cure. And on my third visit with him, I could tell that he was very distraught. Here, he had worked hard all his life. He had 3 beautiful children. He had the disease now that was incurable, that he's lost his faith in God. And you could see the loneliness in his eyes. And the loneliness is something that can affect people's life tremendously, the loneliness of a disease. So I'm sitting there with him and I told him, John, there are people in this world who are cured and never healed. And there are people in this world who are never cured that are healed. And it took him a few seconds to realize what I was trying to say. That sometimes we cannot cure the chronic illness, we cannot cure the chronic pain, but we can heal people from within so they can become fruitful and productive. So in closing, I would like to share with you this very wonderful comments made by Bob Fulghum in his book, because I think in developmentally, we all learned this way back in kindergarten, how to play fair. Don't hit people. And I'm not talking about physically hitting people, but verbally hitting people. Put things back where you found them. Clean up your own mess. Does that resonate with you? Clean up your own mess. Okay? I'm not talking about cleaning your room or cleaning your house. I'm saying clean up your own mess. Think about what's happening to you and say, am I going to do this anymore? And I'm going to change and create a real change. Don't take things that aren't yours, that don't belong to you. Okay? Now, in this era of cyberspace, that's very easily done. We take people's ideas, we take people's innovations, and we sometimes change people's lives by what we say or do. Say sorry when you hurt somebody. That takes great courage. When you've done something wrong. It's one of the things that I practiced for years. When I made a mistake and it caused harm to one of my patients and their families were the first to know. This is what happened. This was unexpected. And this is what we need to take care of it. And they were always willing to help me work toward solutions. Definitely, warm cookies and cold milk are good for you. You need to treat yourself, okay? You need to find what makes you happy. If it's food, if it's activities, if it's exercise, what increases your endorphins in life. Live a balanced life. Learn, think some, draw, paint, sing, dance, play, and work every day. There is this idea of sanctification of daily work, no matter what kind of work you do. That work is important, whether you're washing dishes or doing neurosurgery. That work is important. That's gratifying for you. We should never look down on people by the type of work that they do. And when you go out into the world, watch out for traffic, hold hands and stick together. This is so important to me. Because we're in this all together. And this is what I talk to families and patients when I'm taking care of them. Okay. I had a situation one time when I was with a family and this young man had a drug abuse problem, had liver cancer, and continued to drink. And I told them very candidly in front of the family, your drinking is unacceptable and you need to stop drinking. And he said, I can't. And I said, it's not that you can't, it's that you won't. You have to find the courage to say no. And be aware of the wonder. Okay? Holding hands and being aware of the wonder, the wonderful world that lies ahead of us, and the opportunities we can have, regardless of our disease, regardless of our pain, to move on and make the best of our lives. I want to thank you very much for this opportunity to be with you on these 3 sessions, some of the things that we discussed, and also some of the wonderful questions you had. And I hope that the information I imparted through these 3 lectures will improve the quality of your life and help you to pass this information on so we can make an impact in other people's lives that have chronic pain.